Welcome. I'm going to hand you over straight away without delay to our speakers. We would like to encourage you to join our community of practice. Here is the link. Ask questions of the presenters after this webinar. And during this session, there is going to be two parts. The first part, we will have the introductions with the speakers, and part two is when we really want your participation to ask questions and hear from the Ministry of Health Malawi of this fantastic work that has been taken forward. So Martin Dalston is a technical officer at the World Health Organization in Geneva. He was working in Malawi over the past number of years supporting this work. So he's going to be our perfect facilitator. Over to you, Martin.
Thank you very much, Olive, and thanks everyone for joining. So as Olive said, my name is Martin Dalston. I work currently at the Geneva office of WHO in the Department of Maternal and Newborn Child Adolescent Health and Aging. And I have the privilege to facilitate this webinar where we will hear about the Ministry of Health in Malawi's experience in developing and implementing the quality improvement assessment tools, and they will also share lessons learned in the process. And I'm especially proud to facilitate this, as I, prior to my current position, was working with a team in Malawi as part of the process in developing these tools. So I'm happy to introduce to you today's speaker from the Malawi Ministry of Health. It will be Dr. Malangiso Mbewe, who is the Director of the Quality Management Directorate at the Ministry of Health, and also Selemani Kondowe, who is a Senior Quality Management Officer at the Quality Management Directorate in the Ministry of Health in Malawi. So I think with this short introduction, I think we're ready to get going, and I will hand over to our colleagues in Malawi. Thank you.
Dear Salomon, please go ahead and share your screen.
Yeah, good morning, everyone. I'm Dr. Malangiso here from Malawi. I'm with Selemani Kondowe, my colleague from Malawi. So would like to present on our experience on the quality of care assessment tool. So as Martin has introduced, I'm Dr. Malangiso Mbewe, working with the Ministry of Health in the Department of Quality Management. I'm the acting director there. And my colleague Selemani also worked with us in the department, is the Senior Quality Management Officer in the department. So I will take you through the presentation. I'm sharing the slides, my presentation. All right, so that's the introduction of the presentation. Yeah, the overview of the presentation is outlined like this. We'll discuss about the overview, the tools which we are currently using for assessment of quality of care, the scoring methodology, data entry and analysis, lessons learned and next steps. And then my colleague Selemani will come with a quick demonstration of the Excel platform. So Malawi is one of the countries among the 11 countries implementing quality of care network using maternal and newborn health as a platform. And in 2019, we did successfully adopt the WHO maternal and newborn health and pediatric care quality of healthcare standards. And looking at the need after adopting these standards, we needed to also develop the tools to be able to use for assessments of these standards. So we embarked on a journey of developing the assessment tools based on the standards, but we are also inspired by a program which we are currently implementing in Malawi as the accreditation program, which we are being supported by Council for Health Association of Southern Africa, which help countries also in achieving accreditation standards. So we also learned from this program, which helps us to develop these assessment tools. So the process was consultative, involving healthcare providers from health facilities, national level, as well as partners. And after the first draft, we did pilot the assessment tool in selected facilities, and the collections were made from the field visits. And just to appreciate, we had the support from a lot of partners, and the following partners indeed supported us technically as well as financially: WHO, UNICEF, GIZ, ONSE, White Ribbon, just to mention a few. This is one of the consultative meeting which we conducted as one of the process in the development of this standard. So there are various stakeholders from various departments, including reproductive health departments as one of them. In terms of the framework of the assessment tool, it has got 3 areas where we assess. The input part, these are the inputs which are required for provision of care. So there are tools there which are linked more especially to supplies and equipment. We also have got tools which are used to assess the process of care itself, as well as the assessment of the outcomes, to check the outcomes of the care. In terms of the structure, we have got the assessment tool has got this structure. At the top, we have got like what we call the service element. So the service element in this case, we are saying maternal and newborn health, and or pediatric care. After this service element, we have a standard statement, and then which is followed by a quality statement, and then quality measures or quality inputs. So this is how we have structured our assessment tool. And just to have an overview, as we are indicated with the input tool, we have got a standard overview of that standard, a quality statement, a quality measure. The references, they guide the assessor on what areas to focus on as you are doing the assessment. The same with the audit tool, it has got a standard quality statement, reference, file number, scores, as well as the comments. Just going into detail into the assessment tool, as I indicated, there are several tools which we use for assessment of inputs, mainly focusing on the supplies as well as the equipment which are required for provision of care. And we have got separate generic equipment for maternal and newborn health, as well as the theater equipment. So this is the overview of the assessment tool. As I indicated, at the top here, we have got the standard statement, and it has got its overview, just briefly describing what the standard is all about. And then we have a quality statement, and then quality measures or inputs. So there are a list of these quality measures which assess or contribute to this quality statement. And as I indicated, we have got a reference area where the assessor is guided on what to look for during the assessment. So these are the materials, for example, the supplies, for example, which an assessor would look for during an assessment. We try to make sure that the assessment is more as objective as possible enough. And then there is an area where we indicate a score. So after assessment of each measure based on the requirements for each measure, we indicate a score here. So several of these scores under quality measures, they will contribute to a quality statement score. And then there are several statements under each standard, and these will contribute to the score of the standard up there. And then there's a component of comment where you indicate a comment, more especially focusing on the gaps which have been identified during the assessment. And on each quality statement, there's also an overall statement which also provides more of comprehensive information. This is an example for maternal and newborn equipment assessment 2. So you can see this is a list of equipment and probably the requirements and the numbers which are available, and the function. We also assess the functionality, and there's a score where you assess based on the findings during the assessment on each and every list of equipment. For the process, there are also quite several tools which we use for process assessments. So mainly is the file audit tool as well as the interview tool, mainly in the assessment. So in terms of the file audit tool, this is how it looks like. There is a standard statement as the same with the input, and there's a quality measure, and these are attributes. For us to assess how the care has been provided, we assess this as to check whether his comprehensive history was done, physical examination was conducted, and these are the reference where the assessor should check during the assessment to see if indeed comprehensive history was done. And we select a number of files, and in our assessment too, we have indicate about 5. We select them randomly for at a facility, and each file is assessed based on this, and a score is indicated for each file, and then we have an aggregate score for those selected files, and then a comment depending on the gaps which are in the files. This is an example of a client interview. We also, as I indicated, as part of process of care, we also check on experience of care. So we have here a quality statement, and then the measures based on to check on client perspective. So we also randomly select about 5 clients or patients, and then based on these measures, we assess how the clients or patients have experienced of care. And then we have now an average score based on the assessments. In terms of scoring, we have got 3 levels of scoring. One is the compliant, which means the expectations have been fully met. And then the second one is partially compliant. It means the expectations has at least half met. And non-compliant, it means the expectations are not met to a significant degree. And if a service is not being provided at that facility, then we indicate non-applicable. Just briefly on the meaning of the scores. For example, if a standard or a measure demands that 10 delivery packs should be available and all are available under the input measure, then we say that is compliant. If out of these 10, only about 7 are available, we assess it as partially compliant. And if out of these 10, only about 4 or less are available, it is non-compliant. And also there are other assessments. For example, if a standard or measure requires that there should be a policy with guideline, and as well as implementation of that policy. And when only a guideline is present, but there is lack of implementation, it's partially compliant. Also on another scenario, when there is implementation, but the guideline is not available, then that standard is assessed as partially compliant. So after assessing, then the collected information from the input as well as from the process, which is mainly done by the audit, is aggregated to have now a standard score. And basically, to have a standard score, we look at the documentation reviews, as I've mentioned, a client interview, and as well as observation, and that is triangulated to have the overall score for that standard. All this process above, basically, we are using currently paper-based, and then once that assessment is done and the information has been collected, it is now entered into electronically using an Excel, In terms of lessons learned, so far we have seen that the tool is user-friendly and it can be used even by the facilitators themselves to do self-assessment. And the other area is that the tools also exposes a lot of gaps at the facility level, which require areas of improvement. So I think it also gives the facilitator as well as the assessor to now, after the assessment, to look at which areas need to be prioritized to have an impact in terms of improvement in terms of care. And in terms of the next steps, we are intending to review the tool based on the experiences of the use, so that we take into consideration all the areas which we have noted during the assessment. More especially, we are looking at stratifying maybe to levels, so that each level has got its own tool. And also plan to digitalize, because currently the first part of data collection is actually paper-based. So we want, if we can have something like a tablet, and then information is entered directly into the tablet and then into a certain server. And then I would like to hand over to my colleague, Seleman Kondowe, who will take you to a demonstration on how, after the assessment, the data collection, how now, once we have entered the data into the Excel, how it looks like. Thank you.
Thank you, Dr. Mangizo. I'll take you through the data entry process, as he has rightly said. And he also mentioned that you can do paper-based and then directly and then enter it into an electronic tool. But also other assessors have preferred to directly use the electronic tool. So you can either use just an Excel on a computer, or at times we provide a link. Yeah. When we provide a link, it means we use the Google Drive, so people can share standards to assess, and then because everybody is online, all the data is being aggregated at once, and you have real-time data. So when you provide a link, it means only those that have the link are able to use the tool that has been generated. So in terms of the tool, we have different forms. So this one is for MNH. So we have the other one for kids. So for MNH, as the director said, we have input tool, this one. Then we have the audit tool, which will also go into it. We have the theater list. We have client interview. And then we have MNH equipment. Yeah, so basically those are the two. I think this is the last bit is just the analysis. So on MNH2, so I've taken one of the reports so that you can understand how it works. So he mentioned of quality measure, and then he mentioned of a quality statement and then quality measure, that we have several quality measures that contributes to a score of so these are quality measures. These are quality measures, and this is the quality statement. And for these quality measures. So the scores, when you look at, for instance, this one written up to date clinical protocols, and then you have a drop-down list. Yeah, so you choose. Yeah, if you choose to say probably the protocols are not enough according to the reference, you choose PC. Yeah, it turns yellow, and that yellow, you know what yellow means. But if it is NC, it will turn to red. And if you choose to say it is compliant, it turns green. So as you are changing the colors, as you are making the choices, the quality statement score automatically changes accordingly. Yeah. So in the system, when it is compliant, it is reflected as 100 for that element. When it is partially compliant, it is reflected as 50. Why? When it is not compliant, it is reflected as 5. Yeah. And when you choose not applicable, it becomes 0, but that 0 does not add any value or subtract any value to the aggregate score of a particular quality. So where you put the statements for every gap, make sure you put the inputs, and then the inputs, the comments are put here for every quality measure if it has a gap. And then we advise the assessors to summarize the quality statement score, especially in form of in relation to the gaps that have been identified. So that happens up to the end. So you can use this one. You can do assessment on your phone. You can take it on your phone and then do the scoring on a tablet. It will still give the same results. So we have also the audit tool, which he was talking about, where we have 5 files that are looked upon, and then you have all the attributes written here, the quality statement here, and then the aggregate for a particular quality statement is up here, and then the choices are made for each file. You go to the personal file, the personal history. You score it according to the number of the file. So you make choices accordingly as you have seen it. Yeah. So like that. So when it is not applicable, it becomes white. So the scores, average score is aggregated here, and the average score for attributes are aggregated here, and then at the end we have average score for the quality statement. And then you also put your comments here, and then you summarize the comments for this quality statement here. These quality statements are very important because they form part of the comments for the quality statement are very important because they form part of the quality improvement plan, because they are the reason behind the assessment that we are doing is to identify gaps for possible quality improvement. So I think I'll show you the quality improvement plan that we developed with this facility as an example. So we also have the theater list. So you also score according to the numbers. You make the choices accordingly, whether it's PC, whether it's not applicable, it will come like that. Yeah. So you also have the client interview. The client interview, the team identified some quality statements that requires client to hear it from the client mouth. So those ones were taken and were put on the client interview form. So we didn't just generate things from our head, but we actually wanted to, our assessment tool is actually trying to assess what we have prescribed in the standard document. So everything, I think, in the standard document was actually translated to an assessment tool, so that at the end of the day, we may be able to say, on this standard statement, we haven't done well, or we have done well. So this is the client interview form, and then the scoring is on this average score. And then we have equipment for MNH, which is similar to theater equipment. You also make your choices here according to the numbers that have been found. Then after you've done, when you are making the changes of the score, the standard performance is also changes accordingly. So we have put it according to, we want to check performance according to each standard. So each standard statement. So like here is a summary of standards, standard number 1. So each standard has the quality statements. Yeah, these are quality statements. Yeah, for standard number 1 up to here. So this is the average score for standard number 1. So on the standard number 1, we have, when you look at green, is it blue? Is the input 2 from the input 2, and input 2 also aggregates information from equipment, because equipment is part of inputs. So audit 2 is this, what color is this? Is it ready? Then I color blind, sorry. So this color, yeah. So it gives an average for each quality statement. This one only helps us for us to be able to deep dive on the problem. Say when you have aggregate score, which I'll show, I say we have scored 46, we need to identify why 46. Then you go to each standard. Yeah. What happened? Probably is this standard, standard statement MH 1.10. We check inside why did we score less. So it helps for us to be able to quickly identify the problem. So we have standard number 2, so it goes like that up to standard number 10. Yeah. So that's how it goes. Then after that, we have overall score. So this is an analysis tool. Overall score is a reflection of average for each standard. And then it gives an average score for the facility service element. In this case, it's MNH. Then, as I said, we have a quality improvement plan. After the assessment, we need to develop a plan. So this online or Excel tool will help us to easily have like a quality improvement plan with the facility. So whatever you write on the quality, okay, so we have serial numbering of all the quality statements, and then we have the quality statements, and then this is the aggregate score for all the quality, for that quality statement. That means all the quality measures have aggregated to form, to make this quality statement score 48. And this input comment, is generated from the quality statement. It comes automatically. So whatever you write there, it will come here from the input side. Whatever you write for the same, because one area can be assessed through input and audit. So here it means 1.1A can be assessed through audit and also through input. So it will also be generated automatically. So as you are finishing assessing, you already have this area up to here. So up to down here, you have all the statements. Yeah, all these is what you have put as gaps from the assessments. Then you at the end work with the facility to say these are the gaps that have been generated from the assessment too, and let's have plans. So like for this facility, after the assessment, we had made this plan with them. So like all these action points that were to be made by this time frame. So that goes down to all the elements. So basically, that's how our assessment tool works. And then at the end of the day, we can have scores for several facilities, and you have a general score on how facilities have performed per standard and as an average score. So thank you so much. Yeah, over to you, Tama.
Thank you so very much, Sullivan. and Malagiso for this very informative introduction to the work in Malawi and this practical demonstration of the tool. I'm going to hand over to Martin Dawson, who's going to help share so many of the questions that are coming through in the chat and pose these questions to you. So Martin, over to you.
Thank you very much, Olive, and thanks a lot to both Selemani and Dr. Malagiso for sharing this presentation and walking us through the assessment tools. We received a lot of questions, and I believe there's a lot of interest in this tool. So maybe I can just pose the questions and then you can answer. So the first question would be if this tool does include an assessment of the quality of care at community level.
Yeah, thank you so much, Martin, for that. Yes, indeed, as Malawi, based on the WHO guidance, actually WHO standards have got about 8 standard areas for quality of care assessment. But as a country, Malawi, we adopted an additional standard, standard 9, which focuses on community-based maternal and newborn care. So we have a standard which specifically target community interventions, both for maternal and newborn as well as pediatric care.
Great, thanks a lot, Malagiso. There's another question. Can the tool be used for monitoring? Is it used over time to measure progress in each area?
Yes, it does. Because after each assessment, you have score and a quality improvement plan, and with subsequent assessments, you will be able to see the trend, whether from self-assessments or from external assessments. Yeah, so the data is aggregated, and soon I think after several assessment, we'll be able in future to share that trend on performance of facilities.
Excellent, thanks a lot, Selemani. And there's also been a few questions around the scoring levels. And I think there's an interest to see, on what the basis of the scoring that are used, and the score for the client interview form. How is the thinking behind the scoring scales? Has it been used a scale for the scoring system, and how was that developed?
Sorry, Martin.
Yes, do you want me to repeat the question?
Martin?
Do you want me to repeat the question?
Yes, possible. Yeah.
All right.
Yes.
So I think there were some questions around the scoring methods which you have in the assessment tool. And there was some interest to just understand what logic is behind the scoring in the assessment. Have you used some kind of scoring tool to do that, or how is it weight the scoring?
So yeah, so thank you. The scoring system uses some rules. We have like 48 rule, which says like what Dr. Manzo said, if more than 80% of the items are available, it becomes compliant. If more than 40% of the items are available, it becomes partially compliant. And if less than 40% of the items are available, it becomes not compliant. And also, as he rightly said, in relation to documents, when there's implementation without policy or guideline, it becomes partially compliant. So we have those kind of rules that guide the assessor to give a score. So the assessor basically just give a PC, NC, or or not applicable. But the Excel or the online tool will actually translate that to a score, to a mark, whether it's 100 or 50 or 5.
Actually, during our consultative meeting, during process development, that's how we brainstormed and agreed. We also looked at other assessments which are done by other programs, as I've mentioned. For example, the accreditation program, which is done by COSASA. We also looked at that and try to also work on with our document to see if we can also learn from that and apply to the Malawi context. So it was basically looking at that as what Suleiman has said.
Excellent, Selemani and Malangi. So thanks for clarifying that. There's also a question on timing. How long time does it in general take to perform the full assessment of a facility?
Yeah, on the assessment, it also depends with the services which are being provided at the facility and also the level of the facility. For example, if we look at the primary facility, like the health center level, it might not take a long time. I would say an hour or so, but it depends also on the experience of the assessor, because the assessor also need to be experienced in how to do the assessment. So it also depends on the experience of the assessor. But if you take, for example, as a secondary level structure where a lot of interventions are being performed, then you find that it might also take more time as compared to the lower level. So it also depends on the interventions which are at the facility. That's why in the assessment score, there's an option of non-applicable. So some services might not be applicable to a certain level. Some services might be applicable to another level. Yeah.
Great, thank you. And to follow up on that, I think people are also interested to understand who the assessors are and how they are trained.
All right, so the assessors are basically some experts in those fields. So basically, because we just started a few months ago, these were the experts that also took part in the development of the tool. So we got experts from various fields in those areas, and they helped us in the development of this tool. And we have used the same people to help in the initial assessments that were conducted.
Okay, thanks a lot for that. So there's a lot of questions coming in, which is great. So one other questions that might be useful. Let me just see where it went. So how is the results from the assessment used to improve the quality of care at facilities, and what kind of a follow-up support is provided to the facilities?
Yeah, so in terms of the results of the assessment scores, once the assessment has been done, the team will sit down with the facility level and discusses about the results of the assessment, and then the team provide a presentation of the key findings, and through that, a discussion is conducted to agree on which areas to focus on or prioritize, because as I indicated in the presentation, what we have learned that the tool exposes a lot of issues in terms of provision of care. So you cannot take them all at once. You need to prioritize which ones can we take and which ones can be on wrong time. So with the facility staff, then you agree and they assign a responsible person to do that. Then after that, we have a program of following up on the implementation of these action points, as well as also mentorship support the facilities in the areas where they are not understanding better, and also more especially on the QI interventions. That's also another area which the mentorship focus on. We also make sure that as they are implementing, because there are some gaps which can easily be fixed. For example, if there was the absence of an equipment, then an equipment is bought and it's fixed, that one is solved. But there are other interventions which will require a QI project to be implemented, which might take a month or so. Yeah, so that's an area where we also emphasize on to mentor the facility on using QI tools, on how they can implement a QI project, achieve the desired goal. So there is a follow-up process which we do after the assessment. And the plan is after this initial assessment, then after 6 months, the plan is to come again and do another follow-up assessment with the tool to see how far the facility has gone in terms of implementation. But in between, we also encourage the facility to do self-assessment using the same tool so that they can be checking on themselves on how they are implementing or how they are addressing the gaps.
Thanks a lot for that clarification, Malangiso. There's also a question to see on how widely these assessment tools has been applied in Malawi. How many facilities or how many districts have it been applied to so far?
Yeah, it's about 40 facilities at both levels, primary, secondary, and tertiary institutions that have undergone. It's in 9 districts. Each district has about 4 facilities. Of course, a few have 5, and we also have central hospitals. So we have done it to primary and secondary institutions. We are yet to go to tertiary.
Okay, great. And a follow-up on that is it the same tool used, or are there some different tools based on the level of the facility?
Yeah, so in terms of the two itself, currently is for all this. That's why I think one of the areas as our next step, but based on the experiences we have seen on the ground, that we might need to to put the two in 2 levels.
Sorry, Malangi. So I think there's some issues with the sound. Maybe if you can just move closer to the mic, because we could not hear you. Sorry for interrupting.
Oh, sorry.
Thank you.
Yeah, what
better.
I was saying, yes, okay. So what I was saying is that, yes, currently we are using one tool for the assessments of all the levels, and it's an area where we want to work on, probably after getting an experience of using this tool on the ground. So it's one of our next steps to work on the tool, probably to put it in 2 levels in terms of primary, secondary, as well as tertiary. So that's what we are intending to do based on the experience so far after using the tool.
Excellent, thank you. And someone also asked if you please again can explain how the information of experience of care is gathered. are the random women interviewed who arrive at the facility that day, or how are the women selected?
Okay, in terms of the experience of care, yeah, we at the day of the visit, we randomly select women who have access, for example, antenatal care. So when they are leaving the facility, so we randomly select them when they are leaving the facility and conduct the interviews. We also do random selection of some mothers who are, for example, in the postnatal wards awaiting discharge. We also do some interviews in those women. And there's a component of even those who have got undergone, for example, an operative procedure. We also randomly select some and also do some assessment based on that. So the assessment basically is done to the women whom we find at the day of the visit. Mainly, it depends, but we normally do at the day of the visit, and we select those women who have accessed the care at that facility.
Excellent, thanks a lot for that, Malangiso. And there's also just a question for clarification, if there's a separate Excel tool for the pediatric standards.
Yes, Martin, as a country, after adopting the maternal and newborn healthcare standards, we also went ahead to using the same process to also work on the pediatric quality of care standards. And we did develop, adapt one, and also an assessment tool for pediatric care quality of care standards based on the same process was also developed. And we are also using a similar tool to assess pediatric quality of care.
Excellent, thank you. And so far, is it only in government facilities, or are they also used in private hospital facilities or other non-for-profit or for-profit institutions?
I would say since we have done the first baseline, and we are yet and we are targeting mainly fewer districts whom we have designated as learning sites for quality of care. So in those mainly facilities which were included were public government facilities. So those were the facilities which we targeted, but we are yet to move on to other public facilities, not for profit, like the Christian Health Association of Malawi facilities, to do similar assessments, as well as private facilities. But as so far, we concentrated on our quality of care learning sites in Malawi, which are mainly public government facilities.
Great, excellent. And I think some questions also have been asked in regards to challenges you've been facing. So any of the major challenges you faced during the assessment so far, any lessons or challenges you want to share?
Yeah, I'll start. I think Seman will come in, and I know Bongani is also in. Maybe he can join. But I think what we have experienced in terms of the major challenge that the tool has, as I mentioned, it has uncovered a lot of issues in terms of provision of care, and sometimes if the approach is not really well, it might be so like demotivating, but we normally encourage the facility staff to say this is like a starting point, and we will need to make a plan to move on. So you find that a lot of issues could come out after the assessment for the facility to address. So that might be challenging, more especially also considering the resource constraints, which I think we have as a country to address all the issues which we have uncovered from the assessment. So that's where I think we have noted a big challenge. And the other issue I think is we still need to build more capacity on the approach, as well as on how the facility can approach the assessment in terms of improving or addressing the gaps. We are looking more especially on the quality improvement projects which facility would be required to implement to address a certain issue after the assessment. So those are some of the issues which after the assessment, for example, you could notice that there are those challenges which we needed to address and work on the two, as well as facility as a whole. So yeah, just to mention as an example.
Sorry, did you
use the yeah,
please
just
go
to
ahead,
continue
Selman.
from just to continue. During the assessment, people may choose to use the hard copies, and then you find that now after the assessment, the facility would want to have a score right away there, and then for you to get the information into the Excel, it may take a lot of time. So for those that are computer illiterate, I think it becomes too difficult to do the proper assess and give the results. But if you use an Excel, just an Excel, not online, you find that you have problems now to aggregate everything, because one person will be doing standard number one, the other one standard number two, like that. So to get everything together may find it difficult. But if you use online, it's very easy, because you have real-time data coming in and people can collaborate online. But the problem is that you find that in the other facilities, they are way remote and you don't have internet. So basically, those are some of the issues that, well, that's why Dr. Mangizo said that our next step is to digitize so that you can use it offline and still get the results in time. Thank you.
Thanks very much for that clarification. And there's a ton of questions coming in, and a lot of people congratulations for the great work done. We even have greetings all the way from Iceland, so it's very encouraging. So another question would be if there's any plans at the moment to develop a dedicated cadre of assessors within the system, or how would the plans ahead be when you want to scale up in terms of the assessors?
Yes, Martin, the plan is to have a team of assessors, as well as a team to help out with the quality improvement mentorship, so that we should have a pool of assessors countrywide who, as we are scaling it up, we can use this pool of people to do the assessments, and as well as follow-up mentorship program on the areas which facilities will need to be helped. And as much as we are working on this pool of assessors, we are also encouraging to even use those within the facilities, those who have good experience within the facilities, to also be part of this pool of assessors as we move on in terms of scaling up the program. So basically, those are indeed our plans. Thank you.
Excellent, thank you. And another question is, how often are these assessments planned to be done so you can follow up and track improvements made at facilities?
Yeah, thank you for that question. Actually, the plan for this assessments, the interval is, we have indicated that to be done after every 6 months. But we also, as we indicated, that we encourage facilities to do their self-assessments within at least a shorter interval, more especially quarterly, so that they can already start checking on what improvements are being done. Yeah, so that the external assessors, when they come at a 6 months interval, the facility is already aware on the areas where they have made the improvement. So it's both external assessments to the facility, which the interval every 6 months, facilitate a self-assessment at least on quarterly basis. So that's the framework of which we have agreed on this type of assessment.
Excellent. Thanks a lot. And there's also a question on how do you approach when weaknesses noted in the assessment cannot be solved at the health facility level, but needs district national intervention?
Yes, Martin, and thanks for the question. Actually, yeah, once the assessment has been done, actually as we have indicated that there are a lot of issues which come out of the assessment, some which can be resolved by the facility, some from the need to be resolved at national level, more especially to do with issues of policies, system issues. So we have a forum, what we call a National Quality of Care Coordination Forum. So we share with the findings in this forum. This forum has got partners as well as ministry representative, more especially from the reproductive health department. So we share the finding to this forum and agree on the areas to focus on. And where there's need be, because sometimes others might need, for example, the issues to do with medicines and supplies, from this forum, the aim is to also liaise with the relevant departments which deals with medicines and supplies, so that they should know what is really happening on the ground. So there's this coordination unit at national level where we share the findings after the assessments.
Well noted. Thanks a lot. I think we're running out of time. There's, as I mentioned before, a ton of questions and a great interest in this tool. There's also been some requests if, how they can access the tools or the documents, if there's a possibility for it to be shared. So yeah, we will also follow up on that. But yeah, I think time is running out. So just thanks everyone for attending, and thanks so much to Dr. Malangiso and Selemani for this presentation. And I don't know, Olive, if you have any final words before we close the call.
Yes, thank you, Martin. Can you hear me? Just thank you so very much again, Dr. Bebe Salaman, for this fantastic time to share your expertise and learning and answering so many questions. The number of questions was fantastic from the participants, showing the depth of interest in this topic. So we will post those questions on the community of practice, and we'll follow up with our colleagues in Malawi to continue to answer some of those questions also. Thank you, Martin, for your dedicated facilitation to ensure we got through this great question bank. Thanks to the 185 participants that have joined us today for this webinar co-hosted with the Child Health Task Force and the Network for Quality Improvement. We will share the slides and the documents and the recording by email to you all this week. We invite you to join our upcoming webinar. In this series on country learning, there will be a webinar on Monday, the 22nd of March, led by the Child Health Task Force and supported by the network. This webinar will examine key principles of improving quality of pediatric care and explore approaches and learning from 2 large-scale pediatric quality improvement programs in Ghana and Kenya. Before that, next Wednesday, March 17th, in a series on special topics, the network with WHO, UNFPA, and the Global Network for Collaborating Centers for Midwifery and Nursing will host a network on midwifery and QI and sharing experiences, again from Malawi, and also from the point of care quality improvement work led in Sierra, WHO Sierra, looking at the use of point of care quality improvement to strengthening midwifery learning and practice. So we really look forward to your continued participation in these webinars, asking your questions, developing our learning and our understanding. We thank our country colleagues so much for their time. You can catch up with the network work on the various links that are on the screen. And so thank you again.